and her MS and DO is from the regional RIO Trivandrum, Kerala. She's done a prestigious fellowship from the Sir Ratan Tata Fellowship for Cataract and Community Ophthalmology from Shankar Nethralaya, Chennai. She's also done a fellowship and training in pediatric ophthalmology and strabismus from the prestigious Shankar Nethralaya, Chennai. She's been an associate consultant at the same hospital from 2010 to 13. She's won various awards for her presentations at strabismus conferences, that is POSI and POS, and the WCPOS, which is the Pediatric Ophthalmology Conference, and the Best Paper Award in Strabismus at AIOC in 2022. She's an associate editor at the Kerala Journal of Ophthalmology and the scientific committee chairperson at the Cochin Ophthalmic Club. Ma'am, we welcome you for this class, and we also have our secretary, Dr. Praful Marana, who's the main mind behind this postgraduate education program at DOS and has been running it
Pranita,
for
stop.
years.
Thank you, Dr. Nina, for accepting the invitation. And it's an honor for DOS. You are joining as a speaker. And I hope Pranita must have explained you the what we do at PEP. I hope she has explained to you. And welcome to DOS. And also one more thing. And yes, I was not able to join in time. I'm sorry because the link I was trying a different link, so I was not able to join. And sorry for that. And I think we have already crossed 7:30. So let's start with the talk, Pranita.
Yes, sir.
So thank you very much, Dr. Praful and Dr. Pranita, for the kind invitation. And I'd like to thank DOS for this opportunity. So it's my honor and pleasure to be on this module. And let me start by sharing my screen. Sorry, I'll stop sharing. I think it is. I will share again. There was a trouble. I don't know, due to some strange reason, it is going back to the last slide. Yeah, let me start from the beginning. Yeah, is it now visible?
Yes, ma'am, you can make that.
Yeah.
Yes, it's visible. It's on full screen.
Yeah, so this module is meant for postgraduates, I understand, and we're going to talk about special situations in strabismus, consecutive strabismus, strabismus fixus, and strabismus in craniofacial syndrome. So these are not very commonly encountered in your clinical practice, but you must have an idea about them. So what is consecutive strabismus? So consecutive means which develops after another surgery. So this is an acquired misalignment of the eyes which develops after an initial strabismus surgery. So typically the direction of this strabismus is going to be in the opposite direction to the original strabismus. For example, if you had an esotropia, you get a consecutive exotropia and vice versa. The reported incidence is about 5 to 20% after strabismus surgery, and it's pretty common after esotropia correction leading to a consecutive exotropia. So that's the definition of consecutive strabismus. And if you look at this algorithm, this flow chart, it tells you about how you can classify consecutive strabismus. You can classify them into immediate or delayed. If it's immediate, it could be due to a slipped muscle, improper suturing, or overcorrection. If it's delayed, it's usually due to scar remodeling, due to a stretch scar, or a sensory strabismus. So when you have a patient with consecutive strabismus, you should, apart from your routine clinical examination, you should ask these following questions about the surgery. For example, when was the squint first noticed? How was the squint before the surgery? How long were your eyes straight? And how many previous surgeries have been done? And you must get history about the primary surgery parameters like age of surgery, where was the deviation in the primary scenario, what were the pre-operative angles, try to look at the operation notes if the patient has any, which muscles were operated, how much of surgery was done. So these, all this is very, very important. And always when you're examining the patient in the slit lamp, try to look for the scar of the previous surgery. You can miss it if you do a torchlight examination, but if you do a careful slit lamp examination, you often can pick up the scar over the medial rectus or the lateral rectus or even the vertical rectus, or if it's in the fornix, you can even pick up the ponytail scar. So don't forget to look at old photographs. All of them would be having mobile phones with them. So ask them for the old photographs right from the childhood. Ask for previous surgical summary. Do a good clinical assessment and have a proper plan when you're tackling the consecutive strabismus. So a word about how to differentiate between slipped muscle and stretch scar. Now, I already told you, slipped muscle usually happens immediately, usually within days, whereas a stretch scar usually happens delayed, weeks to months. So that's the first difference. But then, as the word says, a slipped muscle is a muscle which has retracted posteriorly into the muscle capsule along with the tendon. So when you open up, you just see a thin translucent vascular capsule there, no muscle. Whereas a stretch scar is usually due to scar remodeling. So when you hook the muscle at the intended, previous insertion site, what you get is a fibrous scar, which is lengthened in its attachment to the muscle. So you get a thicker, fibrous, amorphous tissue. And if you ask for the type of squint, if you ask for the how the squint is progressive, it would be a gradually progressive thing in stretch scar, whereas slipped muscle would be a little more, faster progression. And if you look at the limitation of ocular movements, it wouldn't be too bad like in a lost muscle, but it would be moderate kind of duction limitation in both the cases. So what's the cause for the slipped muscle? It's often the inadequate suturing. When you're taking the bites, if you do not include the entire muscle tissue, or if you miss a pole, you can get a slipped muscle. As far as a stretch scar is usually due to the absorption of the sutures, which may happen faster in some cases, or due to weakening of the absorbable sutures, or it could be just due to the scar remodeling. And what you do, you have to go ahead and explore the muscle. In slipped muscle, as early as possible, go ahead and retrieve the muscle and advance the muscle to the intended recession site. In a stretch scar also, you have to go and explore. You have to excise the scar and advance the muscle. So these are some key points which will tell you how to differentiate between a slipped muscle and a stretch scar. I hope you got it. So let's move on to consecutive exotropia. Now, this is pretty common, usually happens after an infantile esotropia surgery when the parents are pretty happy with the child's alignment and they forget to do any sort of, follow-up. So you have a manifest outward deviation, which is developing in a formerly esotropic patient after surgical treatment of esotropia. Now, if the exodeviation or more than equal to 16 prism diopters for distance and near, it's concerning and you have to do something about it. So let's look at this picture. This child had infantile esotropia after bimedial recession. She was almost orthotropic. She was lost for follow-up because parents thought she's looking pretty good and she doesn't need any further ocular examination. However, she was amblyopic in one eye and gradually you can see that the eye has drifted out. So this is a consecutive exotropia. So what are the causes for consecutive exotropia? Late onset consecutive exotropia. The main important factor would be presence of untreated amblyopia. Then this has also been noted when you do very large MR recessions, it often leads to some adduction limitation and all the more limitation in convergence. So they develop convergence insufficiency. And if you miss the in presence of inferior oblique overactions, then also this can happen. Development of dissociated vertical deviations can also be a factor for late onset consecutive exotropias. Then, of course, you could have, scar remodeling and late slippage, which can happen, later in the course of the absorption of sutures. So all this will contribute to onset of consecutive exotropia. So what do you do in the initial phase when you get a consecutive exotropia? You have to try the conservative measures. The first thing would be, try if there is any refractive errors, especially try to push in minus lenses so that some amount of accommodation is stimulated and convergence gets better. And you can try patching to promote the improvement in the vision in the amblyopic eye. Orthoptic exercises, especially if there is convergence insufficiency, can be done. Prisms can be given and botulinum toxin in rare cases. So these are some things which we may try. We usually try minus lenses, patching, exercises, and prisms. And if those don't work, we have to go ahead with surgical management. So the dictum is you have to go ahead and explore the recessed muscle with advancement if needed, plus minus lateral rectus recession, depending on the angles. So if the angle is small, let's say less than 20 prism diopters, one muscle surgery is good enough. You can go ahead and do an MR advancement. But if it's more than 20, 25 prisms, you have to do two muscles, which could be medial rectus advancement along with ipsilateral lateral rectus recession. Or if the convergence is very bad, then you could do a bilateral medial rectus advancement. So this is the same child whom I discussed earlier. You can see she had infantile esotropia. Post MR recession, she was ortho. Then she started developing consecutive exotropia, and we advanced the medial rectus along with lateral rectus recession, and she became, better aligned. But remember to treat the amblyopia, otherwise this is going to recur. So this is a short video which you can in which we can see there was no slippage of the muscle or anything here, or it was just straightforward case of medial rectus advancement. Here you can see that the medial rectus must have been recessed about 11 to 11.5 mm from the limbus, and it's advanced almost to its maybe 6 mm from the limbus. And this is the advancement of the medial rectus which is happening, and this is combined with a lateral rectus recession, in which case you will get the total angles balanced with the surgery. Sometimes the patient may not be very open with the surgery, what they've had, or they don't have no idea, in which case you will have to explore and find out whether the recession has been done or resection has been done. So let's move on to consecutive esotropia. Now, this is a manifest inward deviation which has developed in a formerly exotropic patient after surgical treatment of exotropia. Now, if it's more than 10 prism diopters for distance and or at near, and it's persisting beyond 2 weeks, it's a matter of concern. And so most of these patients will be symptomatic because previously they were intermittent exotropes, they were fusers, and now they become esotropes. They'll have double vision. So they will be very symptomatic and they will complain to you about the diplopia. So this was one patient of ours who had intermittent exotropia. Post-surgery, she almost looks ortho, isn't it? But when she accommodates and when she starts focusing at distance, or when she accommodates and reads, she develops a consecutive esotropia. So this was problematic for her. So what are the risk factors for consecutive esotropia? Now the eye was out, it has become in. What could be the reasons? One reason is, if you have missed a lateral gaze incompetence. For example, when you measured in the straight position, the amount you got, and when you measured in the side gazes, the lateral gazes were less than the primary gaze, in which case you should have reduced your surgical dosage by 1 millimeter at least. If you didn't do that, you could land up with a consecutive esotropia. Or the patient could have had a high AC by ratio in the ITS. It must have been associated with a high AC by ratio, the intermittent exotropia, and you missed it, and you went ahead and did the same angle. Then you could land up in a consecutive esotropia. Other things could be, in the presence of an inferior oblique overaction with pattern, you could sometimes overestimate the deviation and you could land up with an overcorrection. Or if you miss the inferior oblique overaction, then also it can produce problems. In the immediate period, if you get consecutive esotropia, which is quite large with abduction limitation and widening of the palpebral fissure, think about a slipped lateral rectus muscle and you should go ahead and explore. So other causes would be uncorrected hypermetropia and amblyopia, but the other ones which I discussed earlier, those are the more important ones. So this is an algorithmic approach to consecutive esotropia. If you have an immediate consecutive esotropia, see if the abduction is significantly limited. Think if it is so, it could be a slipped lateral rectus. If there is normal abduction and there is a small overcorrection, you could try conservative treatment first. Late consecutive esotropia, again with limited abduction, think about scar remodeling and stretch scar. You need to explore here again. If it's normal abduction, again, you could try conservative measures first and then wait and watch. So what's the non-surgical management of consecutive esotropia? You could try all the measures which are discussed for consecutive exotropia here also. here you would try push in plus lenses instead of minus lenses. You would try to give them, hypermetropic corrections. You could try patching. If they have a high AC by ratio, you can give them bifocals. They may actually do better. Prisms and even botulinum toxin injection can be tried. So this is one of our children. He had intermittent exotropia with inferior oblique overaction. He underwent lateral rectus recession with inferior oblique recession. Postoperatively, he looked pretty good, but in 1 week's time, he was back with complaints of the intermittent double vision. And we waited for 2 weeks. More than 2 weeks passed. He couldn't, control the double vision. And so that's when we looked into his AC by ratio. It was high. We gave him bifocals. He became, his double vision got better with the bifocals, and his alignment is maintained on bifocals now. So this was another girl who presented within 3 days after surgery. She had undergone surgery for intermittent exotropia with a large consecutive esotropia. You can see her, there is a limitation of abduction also. So we decided to explore because here we knew that there was some problem with the muscle. So if you can see clearly, I don't know if you can see very well. Yeah, this this is her one pole of the muscle, which is still attached to the indented recession site. But you can see that this pole has actually slipped, so this pole has actually slipped and it was stopped in its position by the stump of the inferior oblique, by the inferior oblique muscle. So this pole was slipped in position. So we had to retrieve that pole and advance it. And, there was a lot of scleral stretching. You can see the uveal tissue shining through the sclera, but she did pretty well. And after the surgery, you can see that her eyes are better aligned. So this was a case of slipped lateral rectus, which we got it back and advanced it. So when you have a consecutive esotropia with normal abduction, what do you do? What is the criteria for resurgery? When it's not amenable to conservative treatment, patient is symptomatic with double vision, and if it's more than 14 prism diopters lasting for more than 3 months, there is a threat to binocular vision. You have to go ahead and explore. If it's a small angle, less than 25 prisms, you can try unilateral LR advancement. If it's more than that, you have to do 2 muscles, either a unilateral LR advancement with a medial rectus recession or a bilateral LR advancement, depending on the case. So this child, whom we discussed earlier, had intermittent exotropia. She became consecutive esotropia after the lateral rectus recession. And we waited for about 3 months, but she was not getting better. So we went ahead and advanced the lateral rectus. Here you can see that the lateral rectus is hooked and it is disinserted and it's advanced closer to the original insertion. Okay, so moving on to the second topic, which is strabismus fixus. Now, this is a rare condition. Strabismus fixus means the eyes are abnormally fixed. It could be one eye or both eyes in a position other than straight ahead. So it could be inwards, it could be outwards, upwards, or downwards. Commonly, we see strabismus convergent fixus, which is the inward deviation, and less commonly, divergent strabismus fixus. So it was Villisika who first identified this condition and differentiated it from the retraction syndromes, because earlier this was thought to be entirely due to retraction syndrome. So let's look at the classification of strabismus fixus. You can classify it into congenital and acquired. Congenital is usually due to fibrosis of extraocular muscles, whereas acquired, the most common cause would be a high myopia. Second, the other causes would be myositis or myopathies or infiltration by amyloid tumors, etc. So again, if you have it, let's look at the convergent strabismus fixus, which is the most common type of strabismus fixus. Again, it can be classified into congenital and acquired. In acquired, it is usually due to myopic convergent strabismus fixus, though you can also get non-myopic strabismus fixus, especially in the elderly. So myopic strabismus fixus is also known as heavy eye syndrome. Non-myopic strabismus fixus, as I said, in elderly, it's known as the sagging eye syndrome. It can also be due to congenital fibrosis of extraocular muscles, myopathies, and myositis, or orbital mechanical causes. But most of the time, it is in a high myope that we see a myopic convergent strabismus fixus. Okay, so what are the clinical features of myopic convergent strabismus fixus? So this usually happens in patients with very high myopia, usually more than 15 diopters, with an extremely elongated globe. And you can see here the globe is typically of this length. So what is the reason for this condition? So it has been proposed that there is a weakness of the intermuscular septa between the superior rectus and lateral rectus. And because of this, the globe herniates superotemporally through the muscle cone. And this was proposed by Yokoyama et al. And thus, the muscle pathways are displaced and the superior rectus slips medially and the lateral rectus slips inferiorly. So there is also some mechanical causes attributed like restrictive forces, which could also limit abduction and elevation. So all these combined forces results in progressive esotropia and hypertropia, which leads to the typical myopic convergent strabismus fixus. So histopathology has shown that there is not just myopathic involvement, there is also a fibrotic component in myopic strabismus fixus. And the basic idea of treatment in these cases would be to restore the muscle pathways. So just like you use a belt to keep your trousers in position, you could use anything to keep the muscle pathways united. So muscle belly union can be tried with sutures or silicone band or Gore-Tex. We can even try myopexy of the lateral rectus by fixing it to the equator, or transposition surgeries can be done. But most of the time, we resort to muscle belly union surgeries because that has been successful in this type of strabismus. So this is a table which compares the strabismus fixus, convergent strabismus fixus in myopes and non-myopes. So it can happen in non-myopes also, but typically it happens in myopes with more than 27 millimeters of axial length. So in non-myopes, obviously the axial length will not be this long. And the esotropia and hypertropia is very, very, very profound in myopes, whereas it is less profound in non-myopes. And if you look at the extraocular muscle pathway through MRI, especially the coronal sections, you can see that there is, medial or the nasal shift of the superior rectus, and this is more profound in myopes, whereas the inferior shift of the lateral rectus is more profound in non-myopes. And the limitation of abduction is quite significant in myopes, and it is less in non-myopes. And if you look at the lid changes, there could be some lid changes in non-myopes, especially the elderly who have the sagging eye will all have all features of age-related lid changes like ptosis, superior sulcus deformity, baggy eyelids. And in this elderly population, when you get this sort of strabismus, it is known as sagging eye. Whereas in the heavy eye in myopes, you have a pseudoproptosis due to the high myopia. So these are differentiating points. How do you differentiate this from the other conditions? So the differential diagnosis would be sixth nerve palsy, but sixth nerve palsy will not have a combination of ESO and hypo. Typically, it will be ESO alone, and FDT will be negative. Duane's retraction syndrome is another differential, but it has typical palpable fissure changes, and FDT is positive. Thyroid eye disease will have the thyroid signs. Trauma will have a history of trauma. So important to make the correct diagnosis by doing a proper clinical examination, looking at the old pictures, doing an FDT and a forced generation test. The FDT may be positive in myopic strabismus fixus, but the FDT may not be negative. It could also be moderately positive. So the key is to do a proper imaging, CT or MRI of the orbits to assess the muscle position, and all the more the position of the connective tissue or the pulley which hold the muscles together, and look at the muscle parts as well as the shape of the globe. So all this will give you a clue that you're looking at a strabismus fixus. So I'd like to share this case of ours. So this was one patient who came to me with progressive esotropia and hypertropia. So this is how she looked when she came to me. You can see the eye is deviated inwards and downwards. So she shared her pictures from childhood. You can see that she didn't have that much of esotropia when she was younger, especially in school. She looked fine, but as she moved to college, the eye started moving inwards. And slowly, you can see that the ESO deviation and the hyperdeviation have increased considerably. So you look at the 9-gaze pictures, there is some limitation of abduction as well as elevation. So this is the myopic strabismus fixus or not. So we have to get her axial length done. Axial length is very high in the right eye. It was 30 millimeters as compared to 23.92 in the left eye. And FDT was mildly positive for the right medial rectus, and FGT was also mildly positive for right lateral rectus. But we did the MRI, we can see a large posterior staphyloma with a globe displaced inwards and downwards. And the coronal sections, you can actually see the lateral rectus is displaced downwards and the medial rectus is displaced nasally. So this is, if you have a dynamic MRI, you can actually look at the connective tissue band, which connects the lateral rectus to the superior rectus, as was shown by Deemer, who did a lot of work on this aspect and proved that it was the degeneration of the connective tissue band which was responsible for this kind of condition. So what did we do for her? So we went ahead and did a modified loop myopixy. This was one of my older videos, which I did with our vitreoretinal surgeon. What we did was we used a 240S band to unite the muscles together, lateral rectus and superior rectus, and anchored them with non-absorbable Ethibond sutures. And along with that, we also did medial rectus recession. Yeah. So you can see she had pretty good results on the first post-operative day. Her eyes were well aligned, and she continues to maintain the alignment even now. So it's very important. If I had done a simple recess resect, she may not have improved because she had this condition. So it's very important to identify the condition and do the correct surgery. So that's about strabismus fixes. We are moving on to strabismus and craniofacial anomalies. So craniofacial anomalies can be syndromic or non-syndromic. And there are various reasons for strabismus and craniofacial anomalies. It could be bony abnormalities, which they are usually characterized about. Muscle abnormalities, they could be excyclorotation of the orbit, they could be displacement of trochlea, neurological factors could be there, or even the surgeries for craniofacial anomalies themselves can predispose to strabismus. So we have to look at all these aspects and it has to be a concerted effort along with the neurosurgeon, the ophthalmologist, and the pediatrician that you have to tackle these cases. So most of them have orbital and extraocular muscle displacement due to the abnormal skull base development and orbit development. And it's also been shown that there is X-like-low rotation of the muscle cone, which alters the muscle pathways. And even people have found out that sometimes even the muscle itself is abnormal. They could be absent muscle, they could be bifid or hypoplastic muscles. And sometimes the craniofacial advancement surgeries, they themselves may produce strabismus. So you should be aware of all these aspects when you tackle this special kind of strabismus. So this picture I've taken from article by Saxena et al., courtesy courtesy Vinay Gupta. So this tells us that you can even, most of them have a V pattern exotropia because of the vertical shift of the horizontal recti. So this picture exactly tells you how the patterns are produced. And these are some of our patients. This young girl with plagiocephaly, she has a left, I don't know if you can see, she has a chronic right head tilt. She has a left anterior plagiocephaly, and because of which she has shallow orbits on the left side. And she seems to be having a left superior oblique palsy because she has a left hypertrophy and a right head tilt. And because of the chronic head tilt, the right side of the face, there is some, mid-facial hyperplasia which is happening on the right side. So the left-sided cranial abnormality has produced a problem in the facial development on the right side. So if this is tackled in a very young age, before the sutures fuse, we can actually totally avoid this. So the head tilt can be totally abolished. So in this case, you can see this patient has a left plagiocephaly, but this picture which I've got here is that of a right-sided plagiocephaly. You can see the flattening of the skull on the right side, and even the superior oblique is found to be very thin on the right side. I don't know if you can notice that this dotted arrow shows you the thin superior oblique. So this picture is also taken from the article by Saxena et al. And it is beautifully showing how the cranial abnormality can cause a problem in the orbital development as well as subsequently in the muscle position. So when you have a plagiocephaly, there is premature fusion of one of the sutures. Usually it's the coronal suture. So usually it's unilateral and it's uneven on one side. So what happens is there is an abnormality in the position of the trochlea. It gets pushed more posterior, or there is a retroplacement of the trochlea. And because of which there is a desagiitalization of the trochlea. What does that mean? Nothing much. It just means that it becomes more parallel to the coronal plane, and because of this, the effective length of the superior oblique muscle is reduced, and it mimics the paresis of the superior oblique muscle, and there is apparent inferior oblique overaction, and V pattern strabismus can happen. So this is one condition which can actually mimic the superior oblique palsy on the same side as that of the plagiocephaly. In hydrocephalus, also you can get strabismus. How? Because there is frontal bossing, and here there is sagittalization of the obliques. That is, they become more parallel to the sagittal plane. This leads to an A pattern due to the overaction of the superior obliques. So this is also a craniofacial anomaly which can present to you. But the typical craniofacial anomaly we see is craniofacial syndromes. Usually the Crouzons, the Apperts, and the less common ones would be the Piefers and others. So here there is, in the craniofacial syndromes, there is premature closure of one or more cranial features associated with a certain, facial appearance, and they are called as syndromic craniofacial anomalies or craniofacial syndromes. So it's not that uncommon. 1 in 25,000 live births, first described by Virchow. This is a child with Crouzon syndrome, you can see here. And how does strabismus happen in craniofacial syndromes? Basically, people have found out that it is due to the extortion of the rectus muscle pulleys. So if you have an inferior displacement of the lateral rectus pulley, it may mimic an inferior oblique overaction and V pattern. And if you have a superior displacement of the lateral rectus pulley, it may resemble a superior oblique overaction and A pattern. So that's how you get the strabismus. And typically, as I mentioned, it's a V pattern strabismus. They may have an abnormal head posture to compensate or to maintain binocular vision, usually EXO, or sometimes you may have pseudo overaction of the obliques, often associated with anisometropia, amblyopia, and proptosis. So it's not difficult to diagnose them because they have the particular facies, like this child with Crouzon syndrome. You can see the proptosis, the beaked nose, and the shallow orbits and the luxated globe. So it's not very difficult to diagnose, but imaging to assess the orbital anatomy and muscle presence and position is very important to diagnose the type of strabismus and how to manage it. Also, take care of the comorbidities. They may have associated exposure keratitis, proptosis, and some of them may even have papilledema due to crowding of the, optic canal, or crowding and leading to raised ICT and optic nerve compression. So these things also need to be taken care of, and there is definite risk of amblyopia, so that also has to be taken care of. So this was one of our patients, this child. This is how he was pre-op. You can see he could be classified as a type of Apert syndrome because he had this peaked head, shallow orbits, V pattern, exotropia, hypertelorism, and he also had a cardiac defect in the form of mitral valve prolapse and an auricular hemangioma. So this is how he is after LR recession and shifting of the LR upwards. So to summarize, craniofacial anomalies or syndromes needs a multidisciplinary approach involving craniofacial surgeons, ophthalmologists, and orthoptics. If you identify it in a very small child, the craniofacial surgery itself may prevent the strabismus from developing, or it may correct the facial asymmetry. So surgical correction of craniostenosis in early age can improve or impact the strabismus. Strabismus surgery should be customized to the altered anatomy. In that particular patient, it could be recess, resect, upshift, downshift, or oblique muscle weakening, depending on what you're finding in that patient. Amblyopia treatment with patching or optical correction is a must. You must monitor these patients post-surgically also for iatrogenic strabismus. And don't forget to take care of the other ocular comorbidities like proptosis, exposure keratopathy, optic nerve compression, etc. in these patients. Thank you. Thank you very much.
Yeah, thank you, Dr. Neena. This was a very comprehensive and a nice lecture. Uh, so I am Dr. Abhipsa. So
Hi.
I'll be asking you a few questions.
Yeah, yeah, sure.
Yeah. So I just wanted to summarize that initially you had talked about consecutive strabismus, again
Yes.
exotropia and consecutive esotropia. So in these cases, I just wanted to highlight that the PGs should know what is the difference between a slip muscle and a stretch scar, again, that you had mentioned. And just I just wanted to ask you a question. How to identify how many muscles or which eye has been operated? Because a lot of patients, they come in the OPD and they don't know. A lot of
So
times
one
they
thing,
don't.
yeah, one thing is your examination. I already mentioned, if you do a proper slit lamp examination, you often can find the scar. Uh, there will be some pigmentation, at least even if it's a surgery, is a very old surgery also. There could be a thin scar or a pigmented line, at the region of the original incision where the sutures were applied. You could do that. Uh, that is some one thing. The second thing would be to ask the patient for, old pictures and ask them for the previous surgery reports. Even if they don't have the surgery reports, the previous pictures would definitely give you a big, clue to what the child was having. Suppose you're having a child with consecutive exotropia. Patient is, let's say, older patient also. He's amblyopic. He's coming with an exotropia, and he says, "I've had a surgery done when I was very young, at 2 years of age or 1 year of age, and it is only in this eye it has been done." And if you see that the previous picture is showing an ESO, you're almost sure it's a consecutive EXO. And then you just have to look at the eye on slit lamp to see if both the muscles have been operated. And if both the muscles in the same eye have not been operated also, you should definitely go ahead and explore and see what's the state of the muscle. Consecutive ET is a little more, difficult to identify, but fortunately they come faster. Consecutive esotropes will come faster to you because they will be symptomatic with double vision. And these patients will not sit at home. They will come to you. If they're not able to fuse or suppress, they will come to you faster. And so the records will be there with them and you can look at it. And again, the scar would be there in, where the lateral rectus has been operated. So you can get, sometimes even you may get, the vessels, maybe, there could be a straightening of the vessels over the region of surgery, which also gives you a clue. So these are some things which I found useful in my practice. I always ask the parents to give me old photos because that definitely is a big help. In today's world, everybody would be having some photos of them on Facebook, Insta, and all that. So they can just show you then and there itself.
Yeah.
Um,
Even their Aadhaar card can show.
Yeah. Even some ID
Yeah.
cards from school
Yeah.
or college or some marriage pictures, all those things you ask
Correct.
them to pull out, they will be able to produce them.
Correct.
Ma'am, one of the resident has asked that is there any role of imaging or ASOCT for identification of muscle position and with history of prior surgeries?
Yeah. I was coming to the same question.
Yeah, yeah. So that is typically is more useful when you have a lost muscle. So it's like, it's quite rare in strabismus surgery to get a lost muscle. We usually get such patients after other surgeries, let's say orbital or ENT surgeries, when they've undergone any surgery through the nose, and they have inadvertently, eaten away the medial wall and the medial rectus. So you get a patient who's landed with a large exotropia, no adduction at all. And sometimes even the optic nerve could also be injured. So in such patients, even before you, because and there will be a lot of hemorrhage in the orbit also. So before you go ahead, you should know whether the muscle is there. Is it worth exploring? So MRI will help you, ASOCT, all these things will help you. Yes, if you have ASOCT in your hospital, very good and done, but many places do not have. You could make it a standard of practice to look at the muscle, where it is right now, so that you could have an idea how far you need to go. Sometimes if it's much behind, like if it's in the mid orbit or anything, I would definitely inform my oculoplasty surgeon to help me, because these are areas where you're not very familiar and you would really need a backup.
Yeah. So thank you for this answer. And my next question will be, how will you identify a high AC by A ratio in a case of exotropia? So you were talking about risk factors for
Yeah.
consecutive esotropia.
Yeah. So definitely you can, just like how you do for, esotropia, when you put a +3 lens, the deviation dramatically reduces for esotropia. If you put a +3, it will actually, increase, or vice versa. You could put a -3 lens and see. So sometimes, having said that, it is not very easy to do, because you have sometimes very small children who come to you and they are not cooperative for all these tests. So it's very easy to miss. So if you get a large distance near disparity, please beware. And you could try other methods, taking the IPD and then checking the AC by ratio also. But the gradient is typically what we do in
Yeah.
the OPD.
Yes.
But if you have lateral incompetence, any distance near disparity, I usually prefer to undercorrect them, explaining that this is the thing. And my policy is not to make, is a little conservative when it comes to intermittent exotropes, because if I feel that they are going to be overcorrected, I generally undercorrect, and I can tell patients about it. But in adult patients, of course, you can, do the proper testing and explain to them that you may need bifocals post-surgery, or you can explain that to children also, to the parents.
So again, this has to be done after a patch test. So
Yeah.
if the
Yeah, so patch
patch
test is very important. Patch test is very important because again, small children may not cooperate for this. So in small children, and we do ITS more common in younger children, it's very difficult to sometimes do it. But definitely, cooperative patients, you have to do a patch test, and at least half an hour. You cannot do more than that in a busy OPD. At least for half an hour. And the clue here is not to let them break their, not to let them accommodate. So, keep the prism over the patch tie, and then only remove the patch, so that they don't get a chance to accommodate, because they have very strong accommodation. They can immediately, accommodate, and you will get low angles again.
Yeah, correct. So my next question will be basically, this question is quite asked in Viva. What is the difference between a sagging eye and a heavy eye syndrome? So this is
So I didn't want to
a
confuse the
favorite
postgraduates
question.
too much,
Yeah.
but I just wanted to simply tell them that a sagging eye is what usually seen in an elderly patient, and a heavy eye is usually seen in a high myope with a strabismus fixus. Whereas if you get a strabismus fixus in an elderly patient, you can get same things, the degeneration of the connective tissue bands. I already mentioned certain points which were, comparing and contrasting uh, the uh, the sagging eye from the heavy eye. So here in sagging eye, the deviation may not be as profound as in a myopic convergence strabismus fixus, where the deviation is very large and huge. And again, the limitation of ductions may not be very large in sagging eye as compared to in a myopic convergence strabismus fixus. And subtle differences could be there, like the shifting of the superior rectus more medially, that is more profound in myopes as compared to the inferiorization of the lateral rectus, which is there in the non-myopic sagging eye. And again, if you look at the axial length is normal in a sagging eye patient, whereas in a myopic patient with strabismus fixus, you have very large, strabismus, very large axial lengths. Then another thing would be, when you look at this has been discussed by Dr. Deemer et al. If you look at the connective tissue band, which connects the lateral rectus to the superior rectus, there will be a very thin degenerated band in the sagging eye patients. Whereas in the myopic patient, you would just get a stretched band. It may not be very thin. So these are some subtle differences, but I didn't want to confuse them, all these things, because these are again topics of debate. We don't have a dynamic MRI in all hospitals. But yes,
Yeah.
so typically a high axial length and the slow progressive myopia, younger patient, all these would be going for a myopic convergent strabismus fixus. Elderly patient with lid changes, they would be having other features of age-related lid changes would be their ptosis. They could be having features of, sulcus deformities and, so that is typically the sagging eye.
Yeah. So just a last question now. So we discussed about plagiocephaly and the apparent SO, paresis. So when a patient who's probably, you can say, if the patient is in teenage or something and that patient walks into your clinic, then how are you going to differentiate whether this patient had plagiocephaly or it's just a congenital SOP? So
Yeah, so the plagiocephaly, if they've not had a surgery done, it will be still there, So you
yeah,
can palpate the forehead. So if the SOP, the apparent SOP would be on the side of the plagiocephaly. So there will
okay,
be, as the picture I showed you, suppose if it's on the left side of the forehead will be flat, and
yeah,
that side the orbit will be shallower. So that is the reason, because of the desagittalization of the trochlea gets pushed more posteriorly, and that's the reason why the superior oblique cannot act very well to its expected, powers. So it becomes a weak superior oblique, and it mimics the superior oblique over, under action, and then the inferior oblique over action is obviously there, and then patient has a left hypertropia when you do a cover test, and patient has a chronic right head tilt. So now when you look at the right side, the right forehead is normal. Okay, that's the left forehead is flatter here, plagiocephaly. The right forehead, the side to which the patient is tilting due to the apparent superior oblique palsy, the right side, the forehead is normal, but the mid-facial hypoplasia will be there if the patient has been tilting for a very long side. Now that will be there in both conditions in a congenital SOP, but the plagiocephaly need not be there in a pure congenital SOP.
okay.
But
Thank
we've
you.
had some patients who have, the young, we have picked it up very early. We can send to the craniofacial surgeon. If they can do an advancement, this tilt can be reduced. And this mid-facial hyperplasia due to the chronic head tilt can be avoided. So that is something that we should know in a young child. Before 2 years, the surgery is possible.
Yeah. Thank you. Thank you, Dr. Neena.
Thank you.
Thank you, ma'am, for that wonderful session and that comprehensive talk on this already complex subject with the complex cases that you have shown. Thank you so much. I'm sure the postgraduates will benefit out of this class and for keeping it so simple and to the point for the students as well. Thank you, Abib sir, for your valuable time and being with us for the discussion and making
Thank
it so
you.
vibrant. And I think with that, we'll conclude the class. This is just a token of appreciation, ma'am. We'll mail this certificate to you as well. And ma'am, we are also planning to share the PDF of all the classes that we have had for the Strabismus session. So if you can share a PDF of your presentation, if there are no issues, then we'll share the presentation PDFs to all the students as well for future reference. With that, we come to an end of this class. Thank you everyone for your time. Good night.
Good night. Thank